Okay, so this is going to be the February MEC Minute, and the topic for this month is going to be CPAP. And I thought about doing this because we've used CPAP for years, but we've never talked about why we use it and how it benefits our patients. So we're going to spend the next 20 or 30 minutes talking about CPAP. So CPAP is an acronym for continuous positive airway pressure. And we use CPAP because we use it as an effective way of treating patients with heart failure or COPD or even asthma who are hypoxic. There are other times you can use it, such as ARDS, but principally we use it for patients with CHF and COPD or acute dyspnea with what appears to be impending respiratory failure. One of the things you need to understand about CPAP is it puts back pressure on the lungs and it increases the functional reserve capacity, meaning it increases the amount of air that is within the lung at the end of expiration. So by doing this, it reduces dyspnea, it reduces the work of breathing, it increases the alveolar pressure, it keeps them open so they don't collapse when the patient expires, and it keeps them open so that there's a greater surface area for gas exchange. So the CPAP helps to keep the airways open, and it helps for improve oxygenation. And the primary reason we use CPAP is to improve oxygenation. And we have seen over the years a marked decrease in the need for patient intubation. And we've also seen a decreased risk of dying from acute dyspnea, whether it's from heart failure or COPD or asthma exacerbation. So it has been a big advent for patients that we care for in the field. When I first started in the world of EMS and the world of emergency medicine, I intubated a lot more than I do now. And it's not just because I have more partners who are taking care of patients with me. It's because we have used things such as CPAP and BiPAP to treat the patients early into the course of their illness so we don't have to intubate them. So we use CPAP to improve oxygenation. And how do we do that? Well, we do it two ways, really. One way is by putting air and oxygen under pressure into the lungs. We are increasing the partial pressure of oxygen within the lungs. So chemical substances, oxygen tends to go from areas of higher concentration to areas of lower concentration. So what happens is if you increase the partial pressure of oxygen, you increase the amount of oxygen that's in the lungs because of CPAP. There's going to be a higher concentration that drives movement of oxygen from the alveoli into the blood supply. So by adding CPAP, we increase the partial pressure, which forces more oxygen into the blood. We do that also because by keeping the airways open and allowing for better air exchange and having increased alveolar surface available for oxygen exchange, we have better oxygen movement as well. So it's not just that we have increased partial pressure of oxygen, meaning a higher concentration of oxygen in the lungs. It's also that we have more lung membrane surface area available to exchange gases and to exchange oxygen. So that's how CPAP improves oxygenation for our patients. This is just a graphic I saw and I thought I'd throw it in there. You know, the normal lungs, they don't quite look like honeycombs, but if you look at the left-sided picture, it looks like honeycombs. But if you have problems with atelectasis or lung collapse or inadequate air supply, inadequate exchange of air in and out, these alveoli can collapse, and as one alveolus collapses, it can recruit others to collapse as well. So it becomes a cascade. As you start getting one or more alveoli fail and collapsing, others will go along just as part of recruitment by this process. CPAP helps reverse that. It helps blow these alveoli back up. It helps them stay open so there's better gas exchange. And more talk about it, CPAP helps by overcoming that inspiratory work of breathing. It makes it easier to move air. It also decreases shunting and improves ventilation perfusion mismatch. So I know in previous conversations I've talked about lung shunting. So in many of our patients who are having respiratory difficulties, they are still getting a normal amount of blood supply to the lung. So they're getting their 5 liters per minute or whatever of blood to the lungs. The problem is if we have airway collapse, if we have alveoli collapse, those alveoli have have blood supply, but they're not open, they're not perfused, so they're not able to exchange gases into that blood supply. So by opening up the airways, which is what CPAP does, by opening up the alveoli, it improves ventilation to those areas of the lung that are receiving blood so that there can be gas exchange. And the other thing that CPAP does is it helps prevent airway collapse during the expiratory phase so that when people are bronchospastic, the airways don't collapse. It does also help redistribute intraalveolar fluid. So if you have pulmonary edema and you have a bunch of fluid within the alveoli, that increased backwards pressure on the alveoli from CPAP helps push that fluid back into the capillaries, back into the blood that's perfusing the lungs, so that it can go out of the lungs through normal venous return to the heart, so you can get that fluid out of the lungs and back into circulation. One thing we don't think about is it also increases our intrathoracic pressure as well as the pressure within the lungs. So it increases intrathoracic pressure. What does that do? It reduces preload. So if you have a patient who's in CHF, they have volume overload. If we increase their intrathoracic pressure by using CPAP, we'll have less blood returning to the heart, which means the heart doesn't have to work so hard to circulate, which means it can help move blood through the lungs and get that fluid out of the lungs and back into circulation. So there is an advantage to increasing the intrathoracic pressure. That sometimes, though, can be an issue because if the intrathoracic pressure is too high, in certain patient populations, it can be bad, particularly patients who've had a head injury. If they have a head injury and you increase the intrathoracic pressure with CPAP, you'll then increase the intracranial pressure because of back pressure up into the brain. So probably for patients with head injuries, we shouldn't be using CPAP. We should intubate the patients and secure the airway. The other thing that CPAP does is it improves lung compliance. It makes lungs more flexible. It keeps the alveoli open and allows them to expand and contract easier. So think about it like blowing up a balloon. When you first get that balloon and it's got no air in it and you start to blow it up, it's small, it's tight. You have to put more pressure in there to inflate it. But as that balloon starts getting bigger, as you blow air into the balloon, it gets bigger, it becomes more compliant, it's easier to get the balloon to expand. Well, that's what happens to your alveoli. As they start to inflate and stay inflated with CPAP, it's easier for them to expand with respiration so that there's better air exchange. I just want to talk a little bit about CPAP versus BiPAP. We use BiPAP mostly at the hospital. We could think about putting it on our trucks, but for now we're going to use just CPAP. So CPAP stands for continuous positive airways pressure, whereas BiPAP stands for bi-level positive airway pressure. And I've got a graphic on the next slide that will explain this a little bit more. CPAP helps reduce alveolar collapse. It enables the alveoli to recruit. In other words, it reduces atelectasis, so as one alveolus expands, the others are more easily able to expand as well. But CPAP does not augment respirations. It doesn't do anything to assist the patient in their respiratory effort, particularly inspiration. But it does splint the airways by keeping the airways open, and it then allows for improved oxygenation. So if our primary focus is oxygenation and improving oxygenation in the patient, CPAP is a great way to go. BiPAP, however, is the bi-level positive airways pressure, which means there are different pressures depending on whether the patient's inspiring or expiring. So on BiPAP, when the patient starts to inspire, the device kicks in and gives extra pressure that helps inflate the lungs. With BiPAP, the expiratory pressure, meaning the pressure that the lungs are against during expiration, is similar to PEEP, which is similar to the CPAP pressure, and this helps oxygenation. With inspiration, there is a pressure increase, and that pressure increase augments or supplements the patient's inspiratory effort. It improves ventilation. It actually helps force air into the lungs, and by doing that, it also helps reduce carbon dioxide levels. So BiPAP splints the airways like CPAP does. It helps keep them open because during expiration there's this constant pressure, but it also provides respiratory support, helps move air into the lungs. It helps augment the patient's own normal inspiratory attempts. And by doing so, it doesn't just improve oxygenation, but also helps reduce carbon dioxide levels. So here's a graphic, and I hope it helps make things clearer. So this is a graphic, and if you look at it here, we have, this is inspiratory pressure. Down here is expiratory pressure, inspiratory pressure, expiratory pressure. So as the patient breathes with BiPAP, the pressures go up and down. And typically, we have the expiratory pressure about 5 to 6 millimeters of mercury, which is about where we start with CPAP. So really, the expiratory pressure for BiPAP is at the same level as if the patient was on CPAP. So that's what I have here. The difference between inspiration and expiration is called the BiPAP driving pressure, and that's that extra kick the patient can get if they are having respiratory difficulty and they take inspiration. And then here down at the bottom, I've got the 0 millimeters of mercury. This is if there's no air movement. Typically, if patients are breathing, these pressures may go up a couple points and down. If you have a patient who's pursed lip breathing and providing their own PEEP, typically their inspiratory pressure is really no higher, or their expiratory pressure is really no higher than 2 or 3 millimeters of mercury. So CPAP helps us at 5 millimeters. We tend to start at 5 or 6. CPAP can go 5, 7.5, and 10. Typically CPAP, we don't go over 10. But CPAP would be this line here. And what happens with BiPAP is our baseline is 5, but with inspiration we can go up to 7, 10, 12, whatever parameters we want to set with respiratory therapy. So this is the contrast between CPAP and BiPAP. So when would we use CPAP? What are the clinical indications? What does our protocol call for? Well, for the protocol, it's typically respiratory distress, which for us usually means pulmonary edema, congestive heart failure, which could be pulmonary edema plus peripheral edema, COPD, and asthma. But we could also use it for patients if they're having respiratory difficulties after a drowning episode, patients who may have atelectasis in the lungs because they're just not moving air well. We use CPAP a lot for sleep apnea. Think about how many of your partners in the fire station are on BiPAP at night. And then we can also use it for ARDS, or acute respiratory distress syndrome, which is something we see at the hospital. Typically, we don't see in the pre-hospital arena unless the patient's been in the community and sick for a while. So these are the most common things that we would use CPAP for. So if you look at COPD and asthma, it's typically there's an obstructive issue, and patient may be able to get air in, but they can't get air out, or they can't get air in or out. There's increased airway resistance because of airway constriction, and this causes reduced expiratory airflow rates. Patient can't get the air out because the airways collapse as they increase their intrathoracic pressure. Well, CPAP helps relieve these obstructive issues. It helps splint the airways open. It helps keep them open by putting back pressure into the lungs during the patient's respirations. It helps with gas exchange issues, principally oxygenation. It can help patients who are becoming tired. So we have seen patients where they're starting to look fatigued. We know they're working hard. We put them on CPAP, and it helps with their air exchange. It helps with their respiratory distress, and we can avoid intubation. And it often can be used in the field as a temporizing effort until you get to the hospital, particularly if you think the patient's going to be a difficult airway. It can also be used to temporize until other treatment modalities are being offered, such as we use it to temporize until the patients can get benefit from bronchodilators or whatever other treatment we may be giving them. Here's pulmonary edema. I just throw up here a chest x-ray. You've got this gentleman with a big heart. His heart's probably twice as big as it should be. You can see that his lung fields look a little fluffy. This here is the hilum on the right. This is the hilum on the left. They're kind of swollen because of swollen vessels in the chest. And then you've got these increased white markings in the lung fields, which is pulmonary edema. That's air in the interstitial, fluid in the interstitial spaces of the lungs, which is what pulmonary edema is. So with pulmonary edema and CHF, it's kind of a restrictive issue. The lungs can only work so well. There's reduced lung volumes because of the pulmonary edema. There's less space in the chest cavity for air and air exchange. We've got fluid backing up in the lungs because of high pressures in the left heart, puts a lot of pressure back into the pulmonary vein, which then makes the patient go into pulmonary edema. So we can use CPAP to help put pressure on those lungs. It improves lung compliance, it improves oxygenation, and it puts pressure onto the alveoli to help force some of that fluid back into the blood vessels, so there's less pulmonary edema. And as I mentioned earlier, it increases the intrathoracic pressure, so we provide some preload reduction to the patient. There's less volume of blood returning to the heart, so the heart doesn't have to work so hard. I would like to caution you that you should avoid using CPAP in patients with CHF if they're hypotensive. If they're hypotensive, I would use CPAP only to temporize as you prepare to intubate the patient. If you think about our DSI protocol, we're going to put the tower of power on with CPAP. With a PEEP valve. That's really a poor man's way of giving a patient CPAP until we can intubate the patient. But if the patient's hypotensive and you can't correct them, they need an airway. Don't just use CPAP long enough to get your airway equipment set up, and then you can get the patient intubated. So if the patient's hypotensive, you have to correct the hypotension before you put them on CPAP. Acute respiratory distress syndrome, just going to talk about it briefly. These patients tend to have hypoxia. Their lungs are stiff. They don't move well. They don't expand well. There's a large intrapulmonary shunt of deoxygenated blood through the lungs and out the lungs back into the heart, and that's because there's inadequate ventilation to the portion of the lung or the alveoli that's being perfused, so the lung cannot oxygenate. We can use CPAP in these early stages to correct the hypoxia. That backwards pressure on the lungs that we give through CPAP helps keep things expanded. Again, keep in mind the balloon, it's easier to blow it up when it's already partially inflated versus if you're starting from scratch. So if the alveoli are already partially inflated as the patient starts to inspire, it's easier to get the airways open than if they're totally collapsed. And by using CPAP, we can reduce that shunting of deoxygenated blood through the lungs and improve oxygenation. And then we can use it for other causes of respiratory failure, whether it's drowning or chemical irritation or infections such as COVID. So we can use CPAP for that. And again, it helps prevent airway collapse during exhalation and improves oxygenation. Again, I mentioned other indications, drowning. If the patient has water in the lungs, they can have trouble with air exchange. They can have atelectasis and collapse of the lungs from the drowning. So CPAP helps that. CO, carbon monoxide poisoning, it helps that. So think about it. If we have a patient who's been exposed to carbon monoxide, the treatment is oxygen. The higher the concentration of oxygen delivered to the lungs, the shorter half-life for the CO. So if you have a patient, CO typically is 2 to 3 hours half-life on room air. If you give them high-flow oxygen, you can reduce that considerably. You give them hyperbaric oxygen at the hospital, you can really shorten the half-life. Well, CPAP is really a way of giving high-concentration oxygen under pressure to the lungs. It's not quite as good as hyperbaric oxygen, but it's kind of the same concept. Hyperbaric oxygen increases the partial pressure of oxygen because it's, the patient's diving to 2 atmospheres or so. Well, if we're doing CPAP, we're essentially increasing the partial pressure of oxygen via a face mask, so the whole body's not exposed, but we're increasing the amount of oxygen available for exchange, which means we reduce the half-life of carbon monoxide. So if you have a carbon monoxide patient or a patient who's been exposed to carbon monoxide, one of your treatment options is intubation. One treatment option is high-flow oxygen. Another treatment option to consider is CPAP to provide more oxygen to the lungs. Organophosphate poisoning, poisoning from pesticides, you can have a lot of airway secretions. CPAP can help that. And then pulmonary infections, we know that works. Just think about COVID. COVID is the big one so far, that we all think about right now. Many patients with COVID can be kept off the ventilator because of CPAP or BiPAP. So it's an easy example that's contemporaneous with our current experiences. CPAP helps these patients. The mortality rate of COVID patients who are put on a ventilator is high. If we can keep them off the vent with high flow oxygen, proning, and CPAP or BiPAP, we're doing the patient a favor. Just talking quickly about CPAP levels in terms of pressures. Typically, when we put a patient on CPAP, we start at 5 centimeters of water, and again, that's a constant airway pressure that they have when they're inspiring and expiring. We'll use that for mild pulmonary edema, and if patient has some really minor contraindications, which I'll talk about in a couple minutes, maybe we could still use it, but at lower pressures. If the patient is looking pretty sick, they've got a moderate severity of illness, particularly like pulmonary edema or dyspnea from their COPD, it's not bad to start at 7.5 centimeters of water. You can skip the 5 and go to 7.5. If they're really fighting, your choice is either CPAP now or intubate in 5 minutes, you can start them at a higher level at 10 centimeters of water. I think that's as high as I would go on CPAP at this time. So, if the patient looks like they're ready to get the tube, but you want to try CPAP, it's okay to start them at 10. Just watch them, make sure they don't develop any complications, but keep an eye on them. But you don't need to go 5, 7.5, and 10. You can start at 10 if they really look bad. But you think you might be able to keep them from being intubated. Just keep in mind that normal physiologic PEEP, so if you walk in a patient who's a chronic lunger and they're doing pursed lip breathing, which means they're PEEPing themselves, normal physiologic PEEP, the best a patient can do is between 3 and 5 centimeters of water. So if you walk in and the patient is a COPDer and you can tell that they're tripoding, they're drooling, and they're pursed-lipped breathing, you might want to start at 7.5 or 10 centimeters of water, since they're probably already PEEPing at about 3 to 5. So where would you start? If the patient is doing that, I would start them at 7.5. If they really look bad, I'd start them at 10. Just want to quickly remind you that the 1st of March, we're going to start using pediatric CPAP. These are the same slides I used last month. Again, the clinical indications are similar to adults. Acute respiratory distress without a pneumothorax. The patient's awake. They have to be a year of age and older, and we have to have a mask that seals properly. We have to be able to maintain their own airway. They have to show evidence of increased work of breathing, and they may show accessory muscle use. These are good patients for CPAP. If the patient's in arrest, if you think they've got a pneumothorax, they're not candidates. If their stomach is distended because they've been swallowing a lot of air as part of the respiratory distress, that's probably not a good thing to do. If they're hypotensive, they're not a candidate for CPAP. CPAP can make hypotension worse, whether you're a child or an adult. Any type of penetrating chest trauma, nausea and vomiting, whether you have to worry about them vomiting into the mask, they're not candidates. Tracheostomy or any recent facial surgery, they're not candidates. Be careful in kids and adults if they have impaired mental status. If they have an active GI bleed or if they're actively vomiting, you can't use CPAP because they can't protect their airway. These patients either need to be given oxygen or they need to be intubated. If they have excessive secretions, you have to think about that. I mentioned the organophosphates. It's all relative. If the patient is a little bit wet, they have some extra fluids in their lungs because of the pesticide poisoning, but they're not salivating a whole lot, you can try CPAP. Facial deformity is a big thing. Think about some of our children with congenital abnormalities. Think of some of our adults. Think about adults with hair on their face. You may not be able to get a good seal. And then think about anybody who's got, again, congenital heart disease, congenital facial disease, or the patient's totally inconsolable and will not cooperate with the process. Just a reminder, we have our templates that are going to be out so you can size the mask to the patient. This is something you need to practice with your crews so you know where the devices are and how to size the masks appropriately. And then we do have the ability to use ketamine to sedate the patients if they need it. Because in children they're going to fight it, in adults some may fight it. In children, as part of our routine, we're going to sedate with some ketamine. If you have an adult patient who needs sedation, you could use either Versed or ketamine. And then always remember that you can give bronchodilators through a CPAP device, whether it's for a child or for an adult. If you have a patient who's bronchospastic, get the CPAP on, give them inline nebulized meds based on the protocol for nebulized medications. Give it as an inline direct into the CPAP airway or CPAP circuit so the patients get the bronchodilators. A Contraindications, I've talked about some of them already. Patients who are in respiratory or cardiac arrest, they need a supraglottic device, BVM, or endotracheal tube. CPAP is not indicated. Patients who have agonal respirations are not going to get better with CPAP. They need to have a artificial airway. Think about the patients with facial deformities. You might want to try fitting masks on different types of patients. You can even think about playing that with that in the station. Clean the mask off between you, but practice getting the mask on properly and being aware of facial deformities. If the patient has a severely depressed level of consciousness, let's say they're an overdose with hypoxia, somebody who's going into respiratory failure because of severe bronchospasm or COPD, if their level of consciousness is impaired, they are not a candidate for CPAP or BiPAP. If the patient's hypotensive, they're not a candidate. If you can correct the hypotension quickly and then get them on CPAP, that's okay. But because CPAP has the potential to increase intrathoracic pressure and impede venous return, CPAP can make hypotension worse. If you have any patient where you're considering a pneumothorax, they're not a candidate for CPAP. If you have a stab wound to the chest, shotgun wound to the chest, auto accident or blunt trauma to the chest, or the patient has a history suggesting they may have a spontaneous pneumothorax with respiratory distress, CPAP is not indicated. The patient has to be able to maintain their airway. So think about that. Again, think about trauma patients with chest trauma who may have a pneumothorax, or patients who have a head injury where you want to avoid increasing the intracranial pressure. CPAP is not a good choice. Patients who are vomiting, again, they can vomit then aspirate if they have the mask fixed on their face, particularly if they're sedated. And then if the patient has significant airway edema, meaning if they have evidence of angioedema of the tongue or lips, or the face, evidence of stridor, then they're not a great candidate for CPAP or BiPAP. So just keep that in mind, because the airway edema can get worse. You may not be able to catch it getting worse because you've got the big mask on the face, or the patient may simply not be able to exchange air. Those patients probably need endotracheal tube. Complications, for us, pressure sores are probably not going to be an issue unless you're transferring a patient from a facility where they've been on CPAP for a while, but patients can develop pressure sores on from the mask, particularly in the area of the nose. Patients can get distended stomachs because the CPAP can push air into the lungs, but it can also push air down into the GI tract. Patients can aspirate. Again, if they vomit with a mask on, the vomit's going to go somewhere and they'll probably aspirate it. Patients can develop eye or sinus irritation from the mask and from the gas. Patients can develop a pneumothorax, particularly at higher pressures, so you have to be aware of that. If you have a patient on CPAP and they acutely become worse, think about, did the patient drop a lung, listen to the chest, do they have evidence of pneumothorax, is the trachea midline, any evidence of tension. So what's going on with the patient if they acutely deteriorate while CPAP is on? One of the things you have to think about is acute pneumothorax. Sometimes patients can blow off too much CO2. That to me is not a big issue for us. If the patient needs CPAP, don't worry about what you're doing to the CO2. Some patients may hypoventilate on CPAP. Typically doesn't. Again, if they're starting to hypoventilate on CPAP, they need a different airway, whether that's an iGel or an endotracheal tube. And then some patients, particularly children, but it's not unique to children, become anxious with the mask. You have to deal with that. So, claustrophobia is common. Encourage the patient, talk them through. If you have to give them a little sedation, that's fine. And when I say little, I mean little, just enough to take the edge off. Allow the patient sometimes to hold the mask. When the patient starts to feel better, they typically relax and allow you to leave the mask on. And then gradually attach the straps as the patient becomes more comfortable. So this suggests that those first minutes of putting a mask on, you may just need to hold it on their face with some pressure for a seal. And then as the patient gets more comfortable, then you can apply the straps. If the patient doesn't tolerate the mask, don't force them. If you can't give them a little sedation, if they're still fighting you, you're really not helping the patient, and you're putting yourself and the patient at risk for injury. So if the patient is becoming combative because of the mask, find a different means of treatment. That's all I have. I did want to talk about CPAP, like I said, because we've talked about or had this in the protocol for years, but I noticed that we never really talked about it as one of these MEC minutes. So make sure you're aware of the equipment, particularly with the pediatric side. Think about how you're going to manage a patient with CPAP. If you don't have a lot of experience with the CPAP equipment on your truck, make sure you know how to use it, because when you need it, you don't have time to do on-the-job training. You need to have comfortable with the device before you have to use it. So that's it. If you have any questions, just let me know or contact your EMS coordinator. Thank you.